Just one word, we record the meeting the first half hour and then at some point we switch it off. So if you want to wait with your questions for after the camera has switched off, but you're also welcome with your questions, and put the questions into the chat also when it's already going on. And Katrin starts with the introduction.
Yeah, thank you. So today we welcome Igor Sauer, and we have the topic extended reality in surgery. So Igor is head of the experimental surgery at the University Clinic Charité in Berlin, and he is an expert in various fields. So the list is quite long, and I only name bio-artificial organs and transplantation. And Igor conducts research, and he is investigating mixed reality in surgery, for example, for image-guided surgery, etc. And my first question is, because our audience has a background in human-computer interaction and not so much in medicine. So Igor, could you kind of explain us how much surgery so far works with mixed reality and which topics you are investigating these days?
Yeah, thank you very much, Albert Schmidt, as well for having me here. As you said, we do a lot of research in experimental surgery addressing problems we do have in surgery. And extended reality, mixed reality, virtual reality, of course, can be of great use in surgery, as we deal a lot with images of the patient's anatomy and have to transfer this into surgical action. So I think in overall we have three fields that is worthwhile thinking about extended reality. This is teaching, this is preoperative planning, and this is intraoperative use. In teaching, for example, teaching anatomy, surgery, radiology for medical students or clinicians, I think there are, you will be well aware of a lot of apps and simulators. And we use those simulators, for example, in minimal invasive surgery, laparoscopic surgery, so surgery via small incisions with long instruments, or in robotic assisted surgery. In doing preoperative planning, we deal a lot with CT scans, MRI scans, computer tomography, magnetic resonance imaging. So we have these slices of digital images, and we browse through these images together with the radiologists, and we have to build up a kind of three-dimensional reconstruction of the anatomy of the patient. And this, of course, is a great field for applying three-dimensional reconstructions, segmented information in mixed, or in this case, even better, virtual reality. And then finally, intraoperative use. Of course, during surgery, we do a lot of imaging as well. So we have ultrasound, we have Doppler ultrasound, so in order to see and detect the perfusion. We use X-ray during surgery with the so-called C-arm or in a hybrid OR. And of course, we get a lot of feedback from instruments we use during surgery, and we get information about the patient. And this is something we would like to introduce into a kind of a mixed reality solution for surgeons. And then, of course, robotic assisted surgery. The surgeon sits in front of a console, meters apart from the actual patient, and uses instruments via hand and foot controllers, so to say, a fly-by-wire system. And this is, of course, something that will benefit from mixed reality at some point. But all in all, it must say that the technical solutions we are talking about here are not very widespread at the present. The interaction is really limited to the conditions we do have in the operating room with its sterile environment, etc. And for example, at the moment, if a surgeon wants to check about the anatomy on the CT scan, for example, he or she has to leave the operating table and will stand in front of a conventional 2D screen and will either put on a second glove and operate the mouse, or will instruct the nurse to scroll up and down. And of course, this is something we would like to change.
So I think, let me just start here with one question on the teaching, because I think that the teaching side seems to be the easiest. And I have studied over 20 years back, and I did as a minor subject medicine. So we got some of the technology side of it in Ulm. And one of the things I realized at that time, it was about haptic feedback with basically cutting through skin, cutting into the bone, whatever this. And I felt this is sort of an interesting thing. Now looking into teaching in medicine today, I think especially before last year, it was very much very traditional style. I think we have seen some of the universities in the US moving away from actually cutting up bodies to like virtual tables, but it seems there is something missing. Can you sort of outline for us, because again, this is sort of a lot of the people here, they want to do research in that area. What are the things in your view that are not there yet? So I think we got over the last years high resolution in vision, we got audio, etc. What are the things that are missing from making the experience when you let's say you do an operation on a simulator versus you do it on a real body or on a cadaver? What is sort of the big difference, and where is sort of the room for improvement?
Well, I think haptic feedback definitely is something that is important for a surgeon and is missing in most of the scenarios. However, you have to keep in mind that the current generation of robots for robot-assisted surgery have no haptic feedback either. So the well-known Da Vinci system has no haptic feedback. So simulating surgical procedure with in VR with the software solution using these consoles actually are quite similar to the real situation. If you think of simulations of surgical procedures in virtual reality, the most advanced concepts are with respect to some kind of orthopedic procedures, so hip replacement or something, where you have a lot of machines and instruments you have to use. But again, what is lacking over there is the haptic feedback. And you have these standard controllers, and these standard controllers, of course, are a completely different thing compared to actually using instruments. So I think this is something we definitely have to improve in order to have an appropriate simulation.
Is there really, just sort of, because I think that's a discussion that happens a lot, is it a good thing to go into sort of the way how it's done in the real world? Like you say, basically improving, or is there sort of also the other path where you say a good surgeon doesn't need to have the feedback? They have sort of, so just imagine we train a whole new generation, more sort of like the computer game style. Obviously, this is sort of in areas where it's not killing people if it goes wrong, much easier to do. But do you think there's sort of the old way where you feel the stuff, where you can touch the tissue, where you can really separate between tissue by sort of how soft, how hard, whatever, sort of, is it really is this sort of the gold thing to go for? Or do you think there is sort of a chance that we go somewhere completely different, where it's much more on the visual side or on even other senses, where we do operations completely different? And I think one of the things is also combining this with AI. At the moment, I think if you cut on a patient, you have to do every millimeter right. You could imagine that you basically do a cut around an organ and it looks for the optimal path. Is there something in the discussion at the moment?
Well, I think, you know, when you deal with tissue, with organs, of course you need to feel the tissue, because this will guide you. For example, for the resection plane, you need to touch this solid node, the tumor, and you need to get a feeling of the surrounding tissue. And when you go through the tissue, of course, you get constant feedback, and you will adapt to what you feel. But I think there's a different aspect in surgery. So you have the manual maneuver, but then you have this overall maneuver. So you have, if you perform a surgical procedure, you start with cutting the skin maybe, and you will end up sewing the skin again. But in between you have, you know, depending on what kind of procedure you have at least 30, 40, 50, maybe 100 steps. And of course, what you can train and what you can use these simulators for is training the different steps in the right order, and getting some kind of complications with this. For example, you know, these lab trainer for laparoscopic surgery, all our young doctors, they have to start with these simulators, for example, for removing the gallbladder, the so-called cholecystectomy. So there are certain risky parts while doing this. And this is something you can actually train quite well with these simulators, especially if you are actually using some kind of instruments similar to what you would use in the real world. So I think you know, what we have so far is of use, is of great use, and is of benefit for teaching surgery. But you know, the feeling for the tissue, how the tissue reacts, you know, you can go through, for example, the liver tissue step by step, and then you will at some point cross a vessel or a bile duct. And this is something, you know, you have to feel, and it's not just about seeing to some extent. And therefore, I think we definitely have to improve these. But with respect to this procedural aspect, I think this is something important, and this is something we are working on. Teaching surgery or learning surgery is a lot about observing. So we, you know, in this pre-discussion, we were talking about medical students and whether they join us in the OR. Yeah, they do this. They just holding hooks and keeping parts of the organs aside. This is something we could do with, you know, we could solve with some kind of passive holder, but we would like to join, we would like to have them joining the team in order to observe how we perform surgery. And this is something during all the years of young doctors learning surgery, they will start assisting, observing the more advanced surgeon. And even, you know, even experienced surgeons will visit other groups, go to other ORs, so-called hospitation, and will look on how they do it. Or if you go to surgical conferences, you will see these videos or live sessions showing surgeons how they do this. So for us, it would be of huge interest in having kind of virtual representation of what is happening in the OR. And this is not just what the surgeon is doing on this in the surgical site, you know, right in front of the organs, but it's also how they interact with the nurses, with the anesthesiologists, etc. So what we are working on is so-called volumetric OR. So instead of having 360 degrees videos, we try to build up a volumetric representation of the OR, of what is happening in the OR. So it's kind of volumetric video. And instead of having fixed positions of the viewer, like in 360 degrees videos, the observer wearing head-mounted displays in virtual reality may move freely within the scene and see the interaction of the different people that are actually working in the OR, working as a team. So it's not just the surgeon. The surgeon without a scrub nurse is nothing. And without the anesthesiologist, of course, you wouldn't even start.
I put a link in the chat list where you, Igor, talked with Angela Merkel about the future of medicine and digitalization in medicine. And we know that there's a lot of data about everybody before people are getting a surgery, which you probably have to discuss with your team, etc. I'm wondering how surgery will change when you have the data all in situ, probably, you know, volumetric, or also like, you know, things like illness that have been 10 years ago. And what's about the information overload? So which way the information can be presented, where are the limits, and where are probably the benefits of all these additional information available?
Well, you know, again, as I said, before we perform surgery, we discuss this individual case a lot. So we have meetings with other doctors, with the radiologists, and you know, if it's a oncological disease, we have these tumor boards where we discuss individually the perfect treatment strategy. So we think a lot about it beforehand, and we enter the OR prepared with this kind of information. Nevertheless, during the surgical intervention, the surgeon must continuously perceive, process, and interpret a multitude of information. And for example, we see the surgical site, we get informed about certain vital parameters. Think of the beeps indicating the heart rate of the patient during surgery. We do take samples, send them to the pathologist, and he will immediately examine these samples, for example, lymph nodes, and will give back some histopathological information. We perform, as I said, imaging during surgery, so determination of the blood flow, ultrasound, etc. And of course, we get information from the tools we use during surgery. Beside this, there is this so-called individual case knowledge. So what do we know about this individual patient, medical history, etc. And we have, as you just mentioned, this kind of domain knowledge. So what is the appropriate treatment? What are the guidelines? What are the results of the studies? And this is something we sometimes even have to discuss during surgery with experts. But, you know, compared to 10 years ago, the situation is not so different nowadays. We do have more screens in our OR, but most of them are conventional 2D screens, usually mounted in a very inconvenient and not ergonomic way next to the surgical site. So I think digitization in surgery is, you know, still a huge topic.
Yeah. Just a little thing we discussed earlier about, like, some of us are trying to explore multimodal interfaces, and I found really interesting that you told me that not only like vision, haptics, and sound is important, but also smell. Can you probably explain to us who not were like you know, conscious in any surgery, what modalities are important in surgery and what is leading? Is it vision, or how important is audio, like sound, or what do you do with smell?
Well, yeah, well, I mean, visual information, I think, is most important. You know, we especially when it comes to laparoscopic surgery, we look at these 2D or 3D screens. When we do robotic surgery, we are even distant to the surgical site and do see the video stream. We discussed haptics. I think haptics are really important, and this is something most of the current systems are lacking, and all the companies are working on providing haptic feedback. Sound, you know, of course, when we perform surgery, this will make some sounds, but this is nothing, you know, body derived or patient derived. We have a lot of sound information, you know, like these beeps from the heartbeat. Then all the machines we use will give some kind of acoustic feedback. And odors or smell, this is something that, you know, that will happen. Usually it's not very pleasant. You know, if there's some kind of tumor, usually parts of this tumor will be necrotic, or if you have an infection, this is something that's, you know, is not very pleasant smell, but this is important or might be important for the diagnosis. You know, diagnosis for ages was done by smell or even tasting. For example, diabetes mellitus, they tasted the urine, these doctors these days, and they, you know, this was kind of sweet, and this is why they called it diabetes mellitus, like honey, urine like honey. So this might sound a bit disgusting now, but nevertheless, you know, smell, I think, is something that happens in the OR and might help, you know, getting extra information on what you are dealing with.
So I jump in. I think I've what I just put into the chat for you looking is sort of a link to the robotic system Igor mentioned, the Da Vinci operation system, just to give you an idea of what it is. And this is sort of, I think, state of the art, but it doesn't include the haptics, as we learned. I looked at one of the papers you recently were sort of publishing together with a team on ultrasound, using ultrasound in AR. And I think this is obviously something we are quite interested in as well. So ultrasound is something, it has a long tradition in medicine. Nevertheless, it's fairly complex. We were last year writing a proposal, and I think I learned how much training it needs. Because usually people don't see anything on ultrasound, so it takes a lot of experience to use it right. So, and then I think that the question is a bit bigger. It's this sort of, you're doing imaging while doing the operation. So like in real time and getting this into the headset. So what is sort of a system you are exploring at the moment in research? Not what basically, is it really, are you using off-the-shelf headsets like the Microsoft HoloLens? How do I have to imagine this? What is the research state of the art in the medical field at this moment if we talk about something like sort of, yeah, image guided interventions or have headsets? What do you use and how do the studies look like? Just because I think, as Katrin said, we are coming mainly from the HCI domain, so it would be really interesting to get sort of from the method side a bit from your experience.
Yeah, so of course we are not hardware developers, so we use what is available, and we, you know, when I first learned about the Microsoft HoloLens, although I don't like Microsoft so much, the HoloLens is I think is a great device. So we got our hands on this HoloLens 1 and the latest generation, and we deal a lot with the use case scenarios. So we test whether it's appropriate to use, for example, the HoloLens during surgery. So we started with experiments having the segmented data, the anatomical information, in this case, liver surgery, the important anatomy. So this is the vessels, the bile ducts, and the localization of the tumor hovering above the surgical site. So the assistant was able to just look up briefly and see this kind of anatomical model of the patient he was operating on, hovering right above the surgical site. What you mentioned with respect to the ultrasound, as I said, during surgery, we from time to time have to use ultrasound, and usually what the situation at the moment is you have this kind of sterile ultrasound probe, this kind of transducer, and you can scan the organ, and then you have the screen of the ultrasound device somewhere next to the surgical site. So usually you are having your hand in front of the above the organ with the transducer, and you look to the side. So this is really really bad hand-eye coordination, and what we tried was to annotate the image generated by the ultrasound right next to the transducer. And if you do this and go above the surface of an organ, you get the feeling of having a torchlight. Basically, you can browse through the tissue right underneath. You see the image right underneath this ultrasound transducer, and this, of course, is improving this hand-eye coordination a lot, and it's much easier for surgeons are not experts in radiology, but we have to use these tools as well. And of course, we know a lot about anatomy, etc. But combining this in this kind of ergonomic way was obviously quite helpful. So come back to your question, we use, of course, standard technology. We try to adapt this. We experiment a lot with hardware we get. For example, these volumetric OR. This was done with some kind of I don't know, these depth cameras from the Xbox. I don't remember the name.
Kinect.
Yeah, Kinect, right. So we combining standard technology, and of course we have some software developers that help us. For example, Christoph Rüger, he's from the Technische Universität, and he was the head behind this software solution with the ultrasound transducer.
Mm-hmm.
So.
Yeah. I don't know, I think this extends a bit what you just explained. Like you said, you work with standard technology, off-the-shelf technology like HoloLens, etc. So now we are about 72 researchers. If you would have a wish list, like, technology that is not there yet, but would be super helpful for you for extended surgery, which direction should we follow to make you happy to really, improve surgery and have the next generation of, I don't know, robotic surgery or AR surgery?
Well, I mean, at some point, at the moment, robotic surgery, of course, is of great interest, especially for more complex surgical procedures. We are very interested in using this kind of technology. And as I said, this is fly-by-wire. These are fly-by-wire systems. So this is not at all automatic or semi-automatic. But at some point, I guess we have to think about semi-automatic surgery using robots. And similar to the developments in autonomous driving, I think we will see such technology breakthroughs in medicine as well. So let's suppose we have an MRI compatible robotic system. At the moment, they are, of course, you can't bring them near to an MRI system. But if you imagine having an MRI compatible robotic system, we would be able to, constantly obtain information from the inside of the body, of the organs we are operating, and this without radiation. And let's assume that we could segment this MRI data in real time. We could reconstruct kind of three-dimensional structures, and then we might interact with these robotic systems in a completely different way. So we might interact in terms of kind of a three-dimensional representation of the anatomy of the patient. And then, of course, these robots might act semi-autonomously. So the surgeon at that point, of course, would have a completely different role, similar to autonomous driving again. He would be the fundamental decision maker and subsequently the supervisor of the process. So if you could provide me such a system, this of course this would be great, and I think this would change the way we perform surgery.
Perfect.
I think there were comments already. I think sort of once you know exact 3D structures and have robotics to do that, you obviously can do things like tumor removal, etc., in places where it's really hard today. But I think Katrin.
I think we now wanted to involve the audience, and Anke has a question and she's ready. So Stephen, if you put her mic on.
Yeah,
it works.
Good.
Thank you for the talk. It's very interesting because I'm also working directly in that field. Now I have to search for my question. Yeah, I actually have two questions. The first one is like, do you have any idea why planning with like 3D methods or virtual reality even is not really standard yet? Like I did research in literature and the first approaches were done in the early 90s.
Yeah, well, I think you mean the segmentation of CT scans or MRI scans.
Green if you do a segmentation.
Yeah. Well, it's of course we bought some software solutions as well in order to do it by ourselves, and we saw immediately that you actually need, you need the experience of a radiologist at the moment, because you have to go through slice by slice and tell the software, okay, this is still the vessel, this might be an artifact. There are more and more AI-based solutions that actually will make it easier to do these segmentations. But still, this is nothing that works in real time. So if you do it by hand or with the most common software and you are a radiologist, it will take at least a couple of minutes to have an adequate representation. You have to rely on this at the end, and therefore you have to do it in a careful manner. So actually I don't know why this is so complicated, but obviously it is. I think it depends on so many aspects. Like sometimes the radiologist will tell you that this is a really bad MRI scan, for example, because the contrast medium wasn't given at the right time or whatever. So there are so many variables that make it difficult, but of course this is something AI will have to address at some point as well. Especially if you think of autonomous driving again, there are cars driving through the streets with all these things happening around the car, and it works as well.
So you hope for AI there?
Definitely.
Okay. Like my second question is, you talked a lot about the haptics. Also, Albrecht asked about that. Like, do you think it would do harm if there would be haptics, like for example, for teaching, like feeling how a tissue would feel like if it's a cirrhotic liver, but if the haptics would be a little bit off from what it feels in the real patient, would you think that do harm, or would it actually do good because you can feel something instead of nothing?
Well, I think so the question is basically, do we need the real feeling, or could we have some kind of artificial feeling? Well, I think, we were talking about the information overload. At the moment, we can even work without haptic feeling, or haptic feedback. But at some point, we could even use this for transmitting some other information. So, for example, when I think it would be important to have at least 3 fingers of some kind of natural feeling when you do open surgery, actually touching the tissue. But I could imagine that you have, I don't know, what is it, the ring finger and this little finger for having some kind of different haptic feedback from a machine or whatever. So, you know, I could imagine using these channels for transmitting different set of informations as well.
Great. So we will now stop the recording.
I just want to have one follow-up question. Perhaps we can leave that on the recording as well. So I think one is the haptics working alone. But I think, as you said earlier, very often this is sort of a joint effort, like one holding a piece, the other one working on it, etc. Is there some work in joint haptics? Because I think I know it from other domains. This is sort of increasing the difficulty of the task from the HCI perspective massively. Creating a haptic experience for something you do alone is much easier than creating a haptic experience that goes over multiple people. Do you think sort of we can detach the haptic experiences from an individual? Or do we really need to look at the whole thing? So basically, if one person is holding something while you work on it, or so I think this question also handover procedures, like sort of is there something where we need multiple people's haptic in one system, or do you think we could really discriminate like it's done with the operating robot? It's basically a single person device what is built.
I don't know whether I understand your question correctly, but of course, I could imagine transmitting this kind of haptic information to an expert that you know, is remote and will assist as an, you know, telemedical approach, will assist the surgeon. If you do this, at the moment you would be able to transmit some kind of video, but again, this haptic information would be of interest for this remote expert as well.
I was more thinking on basically you are with a team of 3 or 4 people operating. One person is obviously the lead, perhaps cutting, but somebody else is spreading it or holding it up. So their actions impact directly what you feel. And this is sort of was the question, sort of.
Oh, I see.
So because that adds a lot of complexity, because having one haptic feedback device that basically gives you feedback where you cut is sort of fairly simple, but combining this with sort of the other sort of variables, which are at the moment people in there, makes it probably much harder.
Yeah. This is really complex, I guess, because, you know, at least in open surgery, of course, it's the lead surgeon, but the first assistant is as important because he will assist the surgeon. He will hold the tissue in a certain way that the first surgeon actually can, you know, use his instruments. The first assistant will use instruments as well. Sometimes it's kind of a joint work. So yeah, definitely. I think this is not just a one man or woman experience. Actually, all the people that are performing this surgical procedure together should get this kind of information.
So we switched the recording off, and there are more questions, and I think Katrin has the overview.